Hello, I'm Steve Perrone, President of the World Federation of ADHD and Professor in the Department of Psychiatry at SUNY Upstate Medical University. I'm here to talk to you today about the International Consensus Statement on ADHD and what it can tell us about the diagnosis and treatment of the disorder. But first, why is it that we need an International Consensus Statement? Well, my motivation was to correct the misconceptions about ADHD that stigmatized people with the disorder and reduced the credibility of their caregivers, and in addition, limit access to treatment. Stigma is real. We can find stigmatizing books for sale on Amazon.com that tell us ADHD does not exist, that ADHD is a fraud. We can read stigmatizing articles in Time Magazine and Scientific American. Time also tells us that ADHD does not exist. And Scientific American tells us that ADHD is an epidemic manufactured by Big Pharma. Why is stigma a problem? Well, stigma reduces access to evidence-based treatments. In 2020, the World Health Organization decided to exclude methylphenidate from its list of essential medicines for children, despite the fact that it had been used safely and effectively for over 4 decades. An international team wrote a letter of complaint and filed a formal appeal. In 2021, the World Health Organization rejected our appeal, stating that the first-line treatment for ADHD in World Health Organization guidelines are environmental, behavioral, and psychosocial. They said this even though the evidence basis for these treatments is weak, as we shall see, and also these treatments are not widely available, especially in low and middle income countries. Stigma reduces access to evidence-based treatment. Before I go into the details of what we found in the consensus statement, let me tell you about our methods. First, I convened a steering committee based upon these ADHD societies from around the world. The steering committee, who were each leaders of these ADHD societies, recommended authors, MDs, and PhDs were represented. As you can see from the countries highlighted in green on this map, we covered a good deal of the world in the members of the authorship that were recommended by the steering committee and who participated in this endeavor. They came from 25 countries and 6 continents. We decided that for a study to be included in the International Consensus Statement, it had to be supported by either a meta-analysis or very large studies, meaning more than 2,000 participants. Before jumping into the results of the consensus statement, let's talk about 3 major myths about ADHD. The first was that it was exported to the world by the United States, typically recently by pharmaceutical companies. Second is that it is a recent invention. And third is that it medicalizes normal behaviors. The first 2 we can see are wrong based on this slide here. This is a graphic we put together for a Nature Reviews article a few years ago. Important to point out that in 1775, an ADHD syndrome was first described in a German textbook, and then later in 1798, it was described in a Scottish textbook. So far from being an American disorder, ADHD was first discovered and described in Europe, even though that term was not used at the time. But the descriptions in those textbooks are very much like the ADHD that we know of today. And we know that ADHD occurs around the world. In the consensus statement, we reviewed meta-analysis of studies of population prevalence, and those studies show that in each of the countries highlighted in blue, ADHD has been found to occur at about a prevalence of 5%, and that prevalence is essentially the same across all of these countries highlighted on this map. ADHD, not an American disorder. ADHD is a problem that affects children, adolescents, and adults worldwide. What about the idea that ADHD medicalizes normal behaviors? In the consensus statement, we document that each of the real-world outcomes listed on this slide are present in people with ADHD to some extent. ADHD puts people at risk for everything from low quality of life, educational underachievement, all the way to delinquency, criminality, suicide, and premature death. These are not normal behaviors. These are serious adverse outcomes that need to be addressed by the healthcare system. And so as not to minimize the effect on the individual, let's take a look at this work of art produced by an anonymous Reddit user. Reddit is a social media platform that has a group devoted to ADHD. And this Reddit user used this artwork to indicate how ADHD affected them in their daily lives. As we can see, not normal human behavior. So, what does the International Consensus Statement actually tell us about diagnosing ADHD? Well, first, let's start with the foundation of diagnosis. In the Diagnostic and Statistical Manual of the American Psychiatric Association, in the ICD-10, there are some differences, but essentially these 5 areas are required. Developmentally inappropriate levels of hyperactive, impulsive, and inattentive symptoms, not normal levels. Symptoms that occur in different settings, so they're pervasive in the child's life or the adult's life. Importantly, symptoms must cause impairments that first occur in early to mid-childhood. Impairment is key to correctly diagnosing ADHD. If you want to overdiagnose the disorder, you can exclude impairment. And the 5th item is that no other disorder better explains the symptoms. And this is key and very important because, as we found in the consensus statement, ADHD frequently co-occurs with other disorder. And this co-occurrence, we now know, has to do with underlying shared etiological causes, not errors of diagnosis. And despite this, many healthcare professionals still believe that somehow ADHD and disorders don't go together. And in fact, here's a quote from a Reddit user, which I'll show you a few quotes like this throughout the presentation. At a meeting with my psychologist, he told me that in a few years' time, there will be no point in continuing my medication because as someone with ADHD goes into their mid-20s, ADHD swaps for a different mental disorder and the ADHD symptoms go away. Well, we know that's ridiculous because ADHD doesn't swap for a different disorder. ADHD is a risk factor for additional disorders that occur typically later in life. We now know that there are strong genetic associations between ADHD and other disorders. This has been seen at both the epidemiologic level in family and twin studies, but also at the molecular level in genome-wide association studies. It's very clear now that, at least in part, one reason for comorbidity is shared genetic and environmental risk factors for shared disorders. One of the associations that sprung out to me when I was looking at the consensus statement, when I was writing the consensus statement with my colleagues, was the association between ADHD and sleep-disordered breathing. I hadn't realized the extent of the literature on this topic, but we now know from a meta-analysis that included 18 studies and 2,500 children that children who suffer from sleep-disordered breathing have an increased risk of the symptoms of ADHD, inattention, and hyperactivity. As you can see here on the right, this is a forest plot. You'll see many graphs like this today in this presentation. Essentially, this line at 0 means there's no association. Anything to the right of the line means there is an association, and the magnitude of the association is the dot, and the uncertainty about the association is the horizontal line. As you can see, most studies find a significant association, and the pooled result across every study, if we put them all together, is this diamond at the bottom, which shows a strong and significant association between ADHD and sleep-disordered breathing. Interestingly, some forms of sleep-disordered breathing can be treated by removing the adenoids and tonsils. And when that is done, these research studies, as a group, when we look at the pooled effect, shows that they reduce the symptoms of ADHD with a standardized mean difference of 0.43. And that value of 0.43 is about half as effective as a stimulant medication. And so this is an important point that clinicians do need to assess the presence of sleep-disordered breathing in people who present with ADHD. The consensus statement also looked at the prevalence of ADHD over time. When I was first being trained as a graduate student in the 1980s, we were told that ADHD disappeared in adulthood. And indeed, that's not true. In this review paper that we published, you can see that when one looks at the full criteria for ADHD, by young adulthood, those who had met full criteria in adolescence, only 15% meet full criteria in adulthood. But when one looks at functional impairment and impairing symptoms, we see that about 2/3 of young adults continue to meet the criteria for ADHD in young adulthood. So ADHD is indeed a persistent disorder. And yet, this Reddit user posted this: "My psychiatrist told me yesterday that as a middle-aged adult, I don't have ADHD because kids grew out of it and just prescribed additional antidepressants." This is a real problem when some children transition from care from a pediatrician to care as an adult, because some healthcare providers who treat adults still don't understand that ADHD can occur in adults. So one of the important clinical aspects of ADHD has to do with the functioning of highly intelligent people. I have some colleagues who have told me that ADHD cannot occur if somebody is highly intelligent or a high achiever. And yet, we know now from this population birth cohort study of over 5,700 children that there were no significant differences among children with high, average, or low IQ and ADHD in the age at which ADHD occurred, in rates of learning disorders, rates of psychiatric disorders, rates of substance use disorders, and rates of stimulant treatment. So essentially, high IQ children with ADHD look very much like lower IQ children with ADHD in terms of all these adverse outcomes of the disorder. So we shouldn't penalize a person when making the diagnosis of ADHD because they're highly intelligent or because they have been a high achiever. When diagnosing ADHD, there are some companies that will try to sell you objective tests for the disorder. And yet, although all of these objective tests have been cleared by the US FDA for assisting in the diagnosis of ADHD, they are not meant to be used as a replacement for a clinical diagnosis. And in fact, I know of no thought leader in the area of ADHD who uses such tests. And yet, it's not uncommon to hear statements like this on the Reddit platform. "My father said this about my diagnosis. Your psychiatrist is rushing to the conclusion, I don't think you need medications. I think it is a problem of studying habits. If it was a neurological problem, then why didn't your psychiatrist do a brain scan or something?" There is a real need out in the world for an objective test for ADHD because there's also a belief that our clinical diagnoses are no good when in fact they're very good. And yet, no objective test can confirm or rule out the diagnosis of ADHD. One Reddit user posted this: "I went to a neurofeedback practitioner who gave me a handheld device with flashing lights to test for ADHD. I had to press a button for specific flashes. Because I did well on that task, she said I didn't have ADHD. But that type of task is not my problem. Paperwork is my problem. Then she told me I have alpha ADHD or alpha wave ADD. Is there such a thing?" Another Reddit poster said, "My doctor wants me to take a 20-minute QB test before diagnosis, but I'm concerned that my test-taking aptitude will somehow muddle the results." Clinicians that use these tests as a way to confirm or rule out a diagnosis are not treating within acceptable guidelines. So, what does the International Consensus Statement tell us about treating ADHD? Well, on Reddit it's summarized by this posting by an adult who finally got medication for ADHD at age 33. And as you can see, this person was very impressed with the results it had on his or her outcomes. And indeed, that's what the literature supports. If we look at the meta-analysis by Sam Cortese and the Unithiades group, here we have a very nice visual presentation of the efficacy and tolerability of ADHD medications for adults. I urge you to look at this Lancet Psychiatry article if you can. Here, no efficacy is 0, and anything that's to the left of this dotted line, or negative numbers, means better efficacy. Anything that's below this dotted line means more tolerable. And what we found, anything that's below the dotted lines means it's less tolerable. And what the group found was that for adults, amphetamine tended to be both more efficacious and more efficacious but less tolerable than methylphenidate. The methylphenidate here is in green, methylphenidate being less efficacious but a little more tolerable. They thought that this difference wasn't so great, so they recommended amphetamine as a first-line treatment for adults with ADHD. When you look at the child data, they were a little bit different because the amphetamine was still more efficacious than methylphenidate, but not by quite as much, and the methylphenidate was more tolerable. That's again the green versus this purple here, was more tolerable than the amphetamine. And so they recommended methylphenidate as the first-line stimulant treatment for children and adolescents. But the main point we can see from both of those slides is that there is a substantial amount of data showing us the efficacy and safety of these ADHD medications, despite the conclusions of the World Health Organization reviewed earlier. And indeed, methylphenidate has also been shown to be somewhat useful for treating emotional dysregulation. You can see many studies have now been done. In this case, efficacy is indicated by being to the left of the vertical line. We can see from the pooled result in this diamond at the bottom that across all these studies, the efficacy of methylphenidate corresponds to a effect size of about 0.34, which is about a third of the effect that a stimulant has on ADHD symptoms, but it is still some effect. So it's good to know when using methylphenidate that you will get some effects on emotional dysregulation. It's also been shown for lisdexamfetamine, a similar effect size, about 0.34, for the effect of lisdexamfetamine on reducing symptoms of emotional dysregulation. Studies have also been done looking at the effects of atomoxetine on emotional dysregulation. And here the effect's a little bit smaller, 0.24, as one might expect, given the differences between stimulants and non-stimulants in general. Now, we all know that executive dysfunction is an important adverse associated feature of ADHD. And here we see in this meta-analysis, looking at a neuropsychological measure of response inhibition, that methylphenidate is actually favored over placebo. In this case, studies to the right favor methylphenidate over placebo by a small margin. It's about, again, 0.3, 0.4, but yet it's significant and real, which is helpful to know that methylphenidate is improving this measure of response inhibition, and also a measure of a sustained attention. So clear but small effects of methylphenidate on these neuropsychological measures of executive dysfunction. What about using methylphenidate with patients that have intellectual disability? I have heard some healthcare providers say that, well, if a patient has intellectual disability, their ADHD is due to their intellectual disability, so they shouldn't be treated for ADHD. Well, it turns out that we have now a meta-analysis of 8 studies comprising 423 children. And what this shows was that when methylphenidate is used in people with ADHD and intellectual disability, there is a very strong effect on improving ADHD outcomes. And here the effect size is almost 0.9, which is essentially the same effect as we would see in people without intellectual disability. And so we should not penalize ADHD patients with intellectual disability by not treating them with first-line treatments for ADHD. Psychostimulant use can increase anxiety in patients. That's certainly been reported. And yet, when we look at the data, a meta-analysis of 23 studies with almost 3,000 children with ADHD, they found that stimulant medications reduced anxiety by 14% compared with placebo. And I show you this slide. It's difficult to read, but just so you can see how many studies are available. And the studies, the dots moving to the left, show us that there are a decreased risk for with stimulant treatment. Now, why is this the case that some patients you may have observed actually have anxiety due to an initial treatment with stimulants, and yet these studies are showing a reduction in anxiety? I think the reason is that there may be in some patients an initial anxiolytic effect of stimulant medication that eventually goes away, and the anxiety that they're experiencing in their everyday life that's associated with their ADHD is what is being improved with the stimulants in these studies. We all know that disruptive behavior disorder is a common comorbidity of ADHD, and one of the more difficult behaviors to treat in child psychology and psychiatry. A meta-analysis of over 1,300 participants found that stimulants were somewhat effective in reducing aggression, oppositional behavior, and conduct problems in youth with ADHD, some who did and didn't have oppositional defiant disorder, as measured by teachers, and moderately effective as measured by parents. And so here, I should point out that these effects were not as strong as the effects of stimulant medication. And so, not as strong as the effects of stimulant medication on ADHD symptoms. They were about half or less, but yet, like we saw for executive dysfunction and emotional dysregulation, there is some impact of stimulants on disruptive behavior disorders. We didn't have any meta-analyses or large studies of atomoxetine, so did not report on that. What about the medication effects on real-world outcomes? All of these real-world outcomes listed on this slide have been shown to be improved with treatment by ADHD medications. Now, they haven't been shown to improve these outcomes in randomized controlled trials, but they have been shown in naturalistic studies, typically using large medical record registries such as are available in Scandinavia, Hong Kong, and elsewhere. These naturalistic studies have been very well done, and although they're limited by not being randomized, by using appropriate statistical controls and very large samples, we can be confident in their results. And in fact, for some of these studies, for example, studies of accidental injuries and criminality, the researchers were able to look at periods of time when patients were on and off medication and showed that when patients were off their medications, they were at greater risk for accidental injuries, at greater risk for being involved in a criminal event than when they were on their medication. And of course, many of these studies are comparing ADHD people receiving medication with ADHD people not receiving medication, and in those between patient comparisons, you also show many of these findings to be statistically significant. But all the findings are statistically significant with one method or the other. Importantly, even having some preventative effect on suicide outcomes. This Reddit poster said, "My psychiatrist agreed that I had ADHD and gave me a trial of Ritalin and Strattera, but my mother was so against giving her kid meth and told me I embarrassed her by looking like a drug seeker." This is one of the stigmatizing issues around ADHD that the stimulant medications are also medications of abuse. Even though we know that treatments for ADHD actually reduce the risk for substance abuse, in the real world, people associate them as abusive medications, and it can lead to this stigma. Unfortunately, the non-medical use of prescribed stimulants is a real problem. In 2019, I published a systematic review which covered 109 studies, and we indeed concluded that the non-medical use of prescribed stimulants was a significant public health problem, particularly non-oral routes of use, which could result in very severe medical outcomes, including death in some individuals. Now, although non-oral use is rare, it does have real and serious medical outcomes. The oral non-medical use is more common and is typically done to enhance academic and occupational performance. I see this as a rising problem in the USA, and I expect we'll see it elsewhere around the globe. This Reddit user said, I talked to my psychiatrist and he said, there hasn't been much research done on how taking medication for life affects the brain. This is honestly my biggest barrier to taking medication. Well, there actually are data on this topic. The Enigma group published 2 papers recently about structural magnetic resonance imaging studies of ADHD, and they concluded quite clearly that ADHD medications do not cause the structural MRI associations observed for ADHD. In this table, they're comparing patients who are currently not taking stimulants and with stimulant use, and also looking at stimulant use in ADHD. And what they found are no differences between the groups who were and were not using stimulant medications in all of these areas of the brain that have been associated with ADHD, because people with ADHD tend to have small but statistically significant reductions in volume in these regions. Interestingly, in this meta-analysis of functional magnetic resonance imaging studies, this group showed that stimulant treatment was actually associated with more typical activations in the brain, but clearly not associated with any adverse effects on the brain. One concern about the stimulant medications in particular has been the potential effect on the cardiovascular system. This is a meta-analysis of 3 studies, a total of 775 adults, found no significant difference in adverse cardiac events between methylphenidate and placebo. Keeping in mind that these medications should not be prescribed in patients with pre-existing cardiac conditions. There had been some concern that methylphenidate might increase the risk for suicide attempts, and now this has been shown not to be the case. These are data from Hong Kong, and what they show here in this graphic you can see on the right, if you look at 0, this is the time of methylphenidate treatment. What they show is that before methylphenidate treatment, there is an increased risk for suicidality, as indicated by this dark line here. These dotted lines are just the 95% confidence intervals. This is the risk for suicide increasing here up to a point in ADHD people before they've been treated. The blue line is the baseline rate of suicide in the population. But as you can see, after they're treated, after time 0, the risk for suicide goes down over time. And so they concluded that rather than causing suicidality, methylphenidate protected against suicidality. There has been a concern that methylphenidate use can increase the risk for psychotic episodes. Using that same Hong Kong database, the researchers found that the risk of psychosis did not differ between periods when patients were on and off methylphenidate treatment. And in 2019, this study of over 23,000 adolescents and young adults in Sweden looking at 23 treated 23 patients treated for ADHD, they found no evidence of an increased risk for psychotic events due to methylphenidate treatment. 1 year after initiation of methylphenidate treatment, there was a 36% reduction in the incidence of psychosis in those with a history of psychosis, and an 18% reduction in incidence in those without a history of psychosis when compared to the period before taking medication. So these new data are suggesting that, if anything, methylphenidate treatment is reducing the risk for psychotic events. So there are, of course, non-medication treatments for ADHD. Let's talk a bit about what we know there. I, by the way, am a clinical psychologist, so I have used non-pharmacologic treatments for ADHD in the past when I was an actively treating clinician, and I understand very well how effective they are. So we'll talk, though, but what do the data say about their utility in treating the symptoms of ADHD? We'll first start with behavioral and cognitive behavioral therapies. Parent training for ADHD has been used for decades, and yet the data are not so clear. Now, first we have to talk about different ways clinical trials can assess outcomes. One approach is to have the parents assess the symptoms of ADHD. But for a parent training method, this is flawed because the parents know what treatment the child is receiving, because indeed the parents are administering the treatment. Another approach is to have an independent assessor, for example, a teacher, who is blind to the treatment group, to have them assess the symptoms of ADHD. This is the gold standard because assessments cannot be biased. So in the following slides, you're going to hear me talk about parent assessments and independent assessors, an important distinction. So here's studies looking at the effect of parent training on the symptoms of ADHD based upon parental report. Again, this line of 0 here in the middle is no effect, and all of these studies to the right, which have the dots or the squares to the right, are showing a significant effect, and the mean is about 0.5. So these studies, when you ask the parent, which is what you hear as a clinician frequently, right? It's what the parent is telling you about the child, suggests that parent training is effective. It's about half as effective as a stimulant medication, but it's still effective according to parent report. But what happens when we look at the independent assessor? When we look at the independent assessor, the effect goes down from 0.5 to 0.12, and it is not statistically significant because the diamond here is overlapping with 0. Independent assessments are not confirming what the parents are telling us. So this is important for two reasons. One reason is that the data suggests that parent training is not good for treating the symptoms of ADHD, number one. And number two, it suggests that what the parent is telling you at the clinical visit might not be completely accurate and may be influenced by their knowledge of having gone through parent training. So please keep that in mind. What about conduct problems? Well, we see, again, for parent report, we see an effect of conduct problems at about 0.4 here, about half as effective as 0.4 for conduct problems is pretty good. That's about as good as a stimulant can do for conduct problems, but this is parent report. And here we have the independent assessor, and we're still seeing the same effect of 0.4, and it's statistically significant, as we can see, because the diamond doesn't overlap 0, and that's great. So it tells us that parent training is very good for improving the symptoms of conduct disorder, oppositional defiant disorder, and in fact, it's about as effective as what have been shown in the studies of stimulant medications. We also, these meta-analyses also looked at how negative parenting changed or improved, and they found by parent report significant improvements in negative parenting, and by independent assessor reports also significant improvements in negative parenting. So parent training does what it's supposed to do. It reduces negative parenting, it improves symptoms of conduct disorder, but it doesn't do such a good job improving the symptoms of ADHD, which is why the World Health Organization is wrong in saying it should be a first-line treatment for ADHD. So parent training is typically used for children. some younger adolescents perhaps, cognitive behavioral treatments, or CBT, is what is used for adults and sometimes also for adolescents. We now have meta-analyses, including almost 900 participants. And these meta-analyses find some associations with moderate improvements in self-reported symptoms and self-reported functioning. But as we'll see, the results are a little bit sketchy given the lack of appropriate controls in some of the studies. So here's a typical forest plot that we've seen before. Here's the line of zero effect. Anything to the right is showing a positive finding. Over here on the left, we've annotated the studies based upon whether they used active controls versus non-active controls. Now, a non-active control is like a waiting list control. They're not doing anything, they're just waiting until they can get the treatment. An active control is experiencing a, if you will, a placebo treatment. So these are the gold standard controls. And when we look at these gold standard controls, their results are not significant because this diamond just overlaps a little bit with this line of zero. The significant findings in these CBT studies are due to the non-active controls. Now, these are all studies. If we limit it to just studies that use blinded assessors, which we saw as before is very important, we see that for the active controls, there is no significant effect of CBT. For the non-active controls, there is a highly significant effect of CBT. Now, I have to say there's some other data on this that we need to consider. This is a different meta-analysis here, where we're now looking at 160 patients with adult ADHD. In these studies, the studies on the left are the waiting list controls, and the studies on the right are the active controls. In this group, in this meta-analysis here, there was some evidence for a significant effect of cognitive behavior therapy. So my conclusion from all of this is that there is some evidence of a small effect of cognitive behavior therapy, about 0.4. Remember, a stimulant medication is about 0.9, so 0.4 is about half. So there is some evidence for a small effect of cognitive behavior therapy on symptoms of ADHD in adults with ADHD. What about meditation-based therapies? There's been an interest in that in the past decade or so. It turns out that although this meta-analysis overall found a significant effect of meditation therapies, it is not significant after removing the waiting list controls. This is in children and adolescents, and they found the same thing for adults. In fact, for adults, it was not significant at all with or without the waiting list controls. And again, waiting list controls are just not suitable because all of the effects of a placebo treatment are not being included in that waiting list control. What about social skills training for ADHD? This is actually a surprising finding to me that this meta-analysis of 11 studies over 1,200 youth found that social skills training for ADHD did not improve teacher-assessed social skills, general behavior, or school performance and grades. So social skills training, not useful for ADHD. If we look at methods, there are methods that are aimed specifically at improving organizational skills. And this was a meta-analysis of almost 900 youth looking at studies of organizational skills. Here we're looking on the left is teacher-rated findings. The teacher-rated inattention was significant, as was parent-rated inattention. The parent effect was bigger than the teacher effect, as we would expect from what we saw in the prior slides, parents being a little bit more, having a bit more of a positive view than the teachers. However, as you can see, most of these studies have used waiting list controls. So we have to be concerned about these findings, although the active control groups are showing some positive findings as well. So the organizational skills interventions do seem to have some positive effect. We need more studies to be more certain about that. Well, let's move on to computer-based cognitive training and neurofeedback studies. In this meta-analysis of neurofeedback studies, we're here looking on the left at parent assessments and here on the right at teacher assessments. And here anything to the left of this vertical line is a positive therapeutic effect. And again, we see therapeutic effects with parents, but we don't see them for teachers. So the current conclusion is that neurofeedback is not useful for ADHD symptoms when we look at the total score. When we looked at the inattention score, there was some effect of teacher assessments, suggesting that there was a very modest effect, about 0.25 of teacher when we looked at the teacher ratings of neurofeedback. And when you look at hyperactive impulsivity, there was no effect on hyperactivity and impulsivity. This is a meta-analysis from 2014. A more recent meta-analysis from 2019 found no effect on inattention symptoms and a small to medium reduction in hyperactivity impulsivity symptoms. Some disagreement between the two meta-analyses, but the general conclusion is that neurofeedback is at best only has a small effect on the symptoms of ADHD and should not be used for treating the symptoms of the disorder. A cognitive training is a method that attempts to treat specific cognitive functions such as working memory. The meta-analyses of the studies that did a good job of blinding raters and had also used active controls found no significant reduction in ADHD symptoms, but they did find some improvements in verbal working memory. No significant effects on math, reading, visual working memory, attention, and inhibition. This graph shows you the effects on verbal working memory, and these are real. So when someone says that cognitive therapy is efficacious, it's true for verbal working memory, but it is not true for the symptoms of ADHD. And here we can see the effect on academic outcomes, solidly not significant for math or reading. Here we can see the effects on visual working memory, attention, and inhibition, again, not effective. What about cognitive training for treating ADHD in preschoolers? This meta-analysis found significant improvements in working memory and inhibitory control, but no significant improvements in flexibility, reward dysregulation, or symptoms of ADHD and oppositional defiant disorder. So again, cognitive training not useful for treating symptoms of ADHD, and now we know for ODD, but does have some positive effects on neuropsychological functions of working memory and inhibitory control. This was a meta-analysis that focused on memory training, again showing that there were short-term improvements in verbal working memory and visual spatial working memory. But there were no convincing effects that these effects were essentially durable over time. And most of these studies lacked active controls. Let's look now at supplements, diet, and exercise. There's now a lot of data showing us that omega-3 fatty acid supplementation is effective for treating the symptoms of ADHD in randomized controlled trials. We can see that in this nice forest plot here, that the effect on ADHD symptoms is positive with a effect size of about 0.3. It's about a third of the effect size of a stimulant, but effective nonetheless. And so omega-3 fatty acid supplementation can be considered as a potential treatment for some people with ADHD, particularly those that, for personal reasons, not want to be on a medication treatment. There was no effect of omega-3 fatty acid supplements on parent-rated or teacher-rated emotional ability symptoms or symptoms of oppositional defiant disorder. So the effect of omega-3 seems to be limited to the symptoms of ADHD and not these other symptom clusters. Here you can see the data on emotional ability as rated by parents, not significant at all. And here you can see the data on emotional ability as teachers, even less significant for with the teachers. What about ADHD and synthetic food coloring? This is a complex meta-analysis by Joel Nigg's group, looking at parent ratings, teacher ratings, and tests of attention, asking what is the effect of food colorants on these ratings of ADHD symptoms. And what they found was that overall, food colors were harmful for tests of attention. They were not harmful as rated by teachers and observers. They were harmful as rated by parents. And so there is some effect here on these standardized tests of attention, because these cannot be affected by rating biases. But the actual symptoms of ADHD are potentially biased because the parents, of course, know what the child's diet is. Of course, food colorants aren't helpful to anybody, so restricting them from a diet may be helpful for some children. Physical exercise is good for anybody, and I think we should always recommend it to our patients. And yet, physical exercise has not been shown to have a statistically significant effect on reducing the symptoms of ADHD. And that's also seen in this second meta-analysis here. So there's two meta-analyses showing us that physical exercise is not useful in treating the symptoms of ADHD. We do know that ADHD is associated with having unhealthy diets. And this does not mean that these unhealthy diets are causing ADHD, but it does mean that they engage in unhealthy diets. And so if you're treating adults with ADHD, they could need guide from a nutritionist to improve their diets and their outcomes as regard to somatic conditions. In the International Consensus Statement, we did identify several modifiable risk factors. Some are only modifiable by society, not by individuals or by clinicians. But there are exposures to children that occur that can lead to ADHD. There are nutrient deficiencies that are associated with ADHD. There are exposures to the fetus that can lead to ADHD. I'm not going to read them all off to you, but you can read about them in the International Consensus Statement. And we would hope, in particular, that policymakers would pay attention to some of these to improve the lives of people with ADHD and the families of people with ADHD. So there's a lot more in the International Consensus Statement, but this is all I'm going to talk to you about it today. To maximize its impact, we have to disseminate it to patients, families, ADHD advocates, clinicians, policymakers, and any other stakeholder groups. You can help by using your social media to spread the word. You can get a copy of the International Consensus Statement at the World Federation of ADHD website. It's now been translated into many languages as well. We even have an abstract in Welsh. I would like to thank the steering committee of the International Consensus Statement. This is not a project I could have completed on my own. All of these people were very helpful, particularly in identifying additional authors to participate in the program. Well, you can help, as I said before, translate the International Consensus Statement into another language, promote it on your social media accounts, cite it in your publications, and give presentations using slides based on the International Consensus Statement. These will be freely available at adhdevidence.org. And consider joining us at the 9th World Congress on ADHD. It'll be in Amsterdam in person, May 18th, 21st, and 2023. Thank you.